Hello everyone. This session we are going to talk about a very important topic, which is occlusion in complete dentures. Now we understand that the entire occlusal scheme, the entire occlusion for a natural dentition, right? For a natural dentition versus a complete denture is totally different, right? Why? Because in natural dentition you have a fixed support, whereas when you talk about the occlusion in a complete denture, you have only tissue support, right? And that tissue support is not fixed. That means whatever principles we are utilizing in the natural dentition, when you're doing crowns, you're doing bridges, implants, all those concepts and formulae are not applicable when you're talking about a complete denture, right? So what we need to understand is that when you deal with occlusion in complete dentures or occlusion per se, there are a few determinants of occlusion, right? Now, what are these determinants of occlusion? They have been classified into three groups majorly. First group consists of the fixed determinants. The second group is a group with variable determinants, and the third one are your general determinants, right? So when you are dealing with fixed determinants, that means those determinants which we as an operator cannot alter, right? We cannot change. They are something which is given by the patient. It is determined by the patient, and the patient gives these determinants. The second group is the group of variable determinants, right? Things which we can alter, right? The curves, the teeth arrangement, things which we can alter. And then there are general neuromuscular determinants which also determine the occlusion, like the muscles of mastication, the joints, and other stuff. So when you talk about the fixed determinants, under fixed determinants, the first thing is your condylar guidance. Now, what do I mean when I say condylar guidance? I mean the angle of condylar guidance, I mean the curvature of the glenoid fossa, right? These things are not in our control. Whatever the patient has, we have to record it from there and then take it forward. Secondly, there is something called as intercondylar distance, right? This intercondylar distance, that is the distance between the right and the left condyle, is given by the patient. Now that depends on the size of the face of a patient. Now it is not required that all the patients are going to have same size, but when you more or less take an average, right? People did a lot of studies on intercondylar distance. They took more than 10,000, 20,000 subjects and measured the intercondylar distance. So we find that the intercondylar distance usually ranges from 90 millimeters to 130 millimeters. So they took out the average of intercondylar distance, which is around 110 millimeters. So some articulators are fixed at this average. They do not accept a different intercondylar distance. You cannot alter it, right? The way you have your mean value articulators. I cannot change the width of the condylar distance there. But then you have adjustable articulators where you can alter it. But the intercondylar distance for a patient remains fixed. Me and you as an operator cannot alter the intercondylar distance, right? We cannot change it. We just need to record it, and accordingly whatever changes have to be done, we will do in the variable determinants which are in our control, right? Third, you have your hinge axis location in relation to the centric relation. This is not in our control, right? What will be the hinge axis location, where it is going to be related to the centric relation? All these things are fixed in a patient, right? Lateral movements Can I alter the lateral movements the patient is able to give me? Whether he moves 2 millimeters lateral, 3 millimeters lateral, protrusive movements, they are not under my control, right? That is what I need to record from the patient. Very important. Bennett shift or Bennett movement. I cannot control it. It is a fixed determinant. Similarly, the centric relation of a patient or centric occlusion of a patient, rest position of a patient, right? These things are all fixed determinants, right? It is not possible for me to change these determinants of occlusion, but we need to record it in order to give a complete, proper occlusion which is required for the patient. Once you're done with this, we have the variable determinants of occlusion. Now, these determinants are most important for the operator. Why? Because we can control these. We can change this. This can be altered. First of them is your incisal guidance, also known as anterior guidance. Right? We are going to talk about this in detail, but we need to understand as to what incisal or anterior guidance is. It is the relative position of the maxillary and mandibular incisors, right? How the incisal edges meet, what is the overjet, what is the overbite, that is called as incisal guidance. Now that is under my control. If I want to increase the overjet, I can do it. If I want to decrease the overjet, I can do it. Change the overbite, I can do it. That is what is called as a variable determinant. Secondly, you have your plane of occlusion. Now, when you talk about the plane of occlusion, we all know that the plane of occlusion should be parallel to the Camper's line, right? We all understand this, but that is what I discussed. How do you decide this line? You put a thread into your plaster or pumice and put it across the patient's face, and after 10 minutes you have all plaster all over the right side or the left side of the patient, right? So what you need to understand is that when we were recording the ala tragus line, when we were recording the Camper's line, we were not very sure as to what we need to record. So somewhere from the inferior part of tragus or middle or any part of it, and sometimes the line is going on to the external ear. So all these things we all have done during our practicals, during doing patients. But what we see in that, you have done wrong dentures, I have done wrong dentures, everybody has done wrong dentures. They have not followed the occlusal planes, the curves. But what happens? The denture still works, right? The denture still works. The patient wears the dentures. Patients have little bit here and there problem in chewing, but they still chew and eat food. So what you need to understand here is that plane of occlusion is a variable determinant, can be altered, we all do it, but there is just a range of less than 10 millimeters which can be altered, right? Sorry, less than 10 degrees. The plane is in degrees. So not more than 10 degree upper or lower can be done if you change the occlusal plane, but still it is in our control. We can try and alter it. The third part is your compensating curves, right? So when you talk about compensating curves, we have your curve of Spee, you have the curve of Wilson, right? All these curves can be altered, right? I can change the position of the compensating curves. Next is your cusp height and cusp angulation, right? We have already read about different types of cusps. So we know that the cusp height and cusp angulation can be altered. If I want, I can do some selective grinding, reduce the 33 degree to 25, 24, 28, wherever I want, bring it down to 0 degree cuspless tooth. So that means the control of cusp height and cusp angulation lies in the hand of an operator. That is what is called as a variable determinant, right? And then of course your overjet, overbite, we have already discussed those points. Now next comes your general considerations, right? The general considerations or the general determinants of occlusion. So when you say general determinants of occlusion, you have to understand that we are talking about the temporomandibular joints and the muscles of mastication, right? That is what we are looking at when we are talking about the general determinants. To record a centric relation, you require these determinants. Now, these determinants cannot be altered, but what you need to understand here is that there are anterior determinants, there are posterior determinants. The closer the tooth to a determinant, more it will be influenced by it, right? So what do we mean by this? If I'm talking about the TMJ, right, I'm talking about the temporomandibular joint, this is a posterior determinant, right, like the condylar guidance. So this is going to affect the molars and premolars more as compared to the incisors. Similarly, when you have the anterior guidance, right, the anterior part, which is the anterior determinant, this is going to affect my incisors or the anterior teeth more as compared to the posteriors. So we have to remember that there is something which is called as articular equilibrium, right? So this equilibrium should always be maintained when you have to, when you are dealing with the harmony in occlusion, right? So that is what we need to understand, that these are different determinants. The TMJ or the posterior determinants are going to affect more on the teeth which are closer to it, and all other determinants are going to act on the anterior part more because they are closer to the anterior teeth. Now when you talk about the we have already discussed all these determinants. So what we need to discuss now are the different occlusal concepts in complete dentures. So when you talk about different occlusal concepts in complete dentures, the first one is called as bilateral balanced occlusion, BBO, bilateral balanced occlusion. The second term is called as a monoplane occlusion or a non-balanced occlusion, right? And the third main concept which is used is called as lingualized occlusion, right? So these are the basic types of occlusion which are involved in complete dentures. Now what you need to understand when we start talking about all these different occlusions and their factors, so let us first talk about the bilateral balanced occlusion. Now this bilateral balanced occlusion is absent in natural teeth, right? You do not have bilateral balanced occlusion in natural teeth. It is present only in complete dentures, right? It is present only in complete dentures. We need to give this in complete dentures. Why? We have already talked about it, because the denture base is movable, right? It is not fixed. So I cannot have when we talked about the Christensen phenomena, now if you place your anterior teeth edge to edge, the posteriors are disoccluded, right? That is what is Christensen phenomena. If a denture patient does that, if the denture patient brings the teeth anterior edge to edge and the posterior get separated, won't the denture lift up? Right? If the patient moves lateral and only canine takes up the load, won't the denture lift up? So that is the problem with the denture. So what am I aiming at when I'm talking about a bilateral balanced occlusion? I want all contacts everywhere, all movements, all the time. Right? Always all my teeth should come in contact. That is what is bilateral balanced occlusion. So what I don't want you to remember the definition, but I want you to know what a bilateral balanced occlusion means. So this means that you have bilateral simultaneous anterior and posterior centric and eccentric concepts, right? Eccentric contacts. So what you need to understand here is that when the patient is moving into protrusive, edge to edge, all the teeth should come in contact. If the patient is doing centric relation, centric bite, centric occlusion, all the teeth should come in contact. If the patient is doing a lateral movement, like now when I do a lateral movement, only canine comes in contact. That is called as canine guidance. But here when I do a lateral movement, I require all my teeth to come into contact, right? That is what is bilateral simultaneous anterior and posterior contacts in centric position as well as all the eccentric positions. At no given point of time, at no given movement, whatever the patient does, the teeth should leave contact when touching, right? So when the patient is sitting at rest, I don't want the teeth to touch, right? That is rest position. But the moment patient touches or bites on the teeth, I want that to move whenever the patient glides anterior, forward, lateral while chewing. All the teeth on both the sides should come in proper contact, right? That is what is called as a bilateral balanced occlusion. So this helps us in achieving cross arch balancing, right? Cross arch balancing. This cross arch balancing will basically increase the denture stability, right? This will basically increase the denture stability. Otherwise, with any kind of lateral movements, the denture is going to move out. Now that is what we talked about, that when we were talking about mastication, right? When you talk about mastication or the vertical forces, during this duration when the patient is chewing, bilateral balance is not very important, though it is important but not very important. But when you are talking about any kind of horizontal movement or any kind of rotational movements or any kind of functional movements, right? So for all these movements, horizontal, rotational or functional, it is important to have a bilateral balance, right? If you do not have a bilateral balance, as soon as the patient starts speaking, there are some teeth contacts. The moment you start getting these teeth contacts, it will lead to the fracture of the restorations, right? Fracture of the denture, movement of the denture. So it is very important that the bilateral balance is maintained when you are dealing with the horizontal, rotational, functional forces. That is the main purpose. But just contrasting to this, there was a concept given by Shepherd in 1964, and he gave this very famous statement which is called as enter bolus, exit balance. So what do you mean by this statement? This means the moment some bolus enters into the patient's mouth, the moment patient starts chewing something, the balance is going to exit, right? That means there is going to be absolutely no balance in the occlusion when the bolus enters. So he said there is no purpose of giving a bilateral balance, right? If it is not going to get maintained when the patient is chewing, there is no purpose. But we understand that the patient is going to chew for not more than 20 minutes in a day, right? If I ask you how much time do you need to eat food, right? To eat food, you require not more than maybe 5 minutes a meal, provided you're not watching Netflix along with it, right? So if you're watching your TV shows or playing a game or chatting on WhatsApp, maybe your duration of breakfast, lunch, dinner goes up to 30 minutes. But here what we are concerned about is the actual mastication time, the time when the teeth are coming in contact, when it is chewing the bolus. That time is not more than, even when you're chewing, right? If I'm chewing for 1 minute, it is only 30 seconds that the teeth are coming in contact, right? When you chew. So it is a very fast dynamic movement when you are chewing food. So that is what is said, that we do not require a bilateral balance when the patient is chewing. So let the balance exit. It is not a problem. But when the patient is not chewing and talking, like I'm doing phonetics, deglutition, all these functional movements, you definitely require that there should absolutely, the denture should be stable. They should not move. And that thing can be achieved only when you have a bilateral balanced occlusion. Though it is important that when you are dealing with the bilateral balanced occlusion, we must have a very good, firm, resilient ridge so that the tissue denture does not move. So we'll talk about it when we are talking about the monoplane and the other occlusions. Next concept is the concept of lingualized occlusion. What I mean when I say lingualized occlusion, this means that the maxillary lingual cusps articulate with the mandibular occlusal surfaces in all the movements, right? In centric movement, in working side, in non-working side, right? So all the movements, only the maxillary lingual cusps, right? That means in lingualized occlusion, the maxillary buccal cusps are of no use, right? They are not used, maxillary buccal cusps. Now this kind of an occlusion is also called as motor and pestle type occlusion. Motor and pestle type. And lingualized occlusion is not a balanced occlusion, right? It is not a balanced occlusion, right? So that is what we need to remember, that motor and pestle type occlusion is the lingualized occlusion. All the forces for the maxilla is going to be on the functional cusp. So why have we removed the eccentric contacts, right? What we have removed is the eccentric contact on opposing sides, because you do not have a maxillary buccal cusp. So when you do not have an eccentric contact, the chances of losing a denture stability are going to be really less, right? So that is what is the purpose of doing a lingualized kind of occlusion, right? So we have just understood the outline of occlusion, the basic determinants, and how is a bilateral balance different from the natural dentition. What are the different determinants? What is bilateral balance? What is lingualized, right? So this is all about in this session. The next session we will talk about monoplane and the other factors and all other things required for your occlusion, right?